the persons are directed to ask for their questions in the chat. We're not taking questions in the middle of the presentation. And only taking questions that are written in the chat, okay? Sister Cambridge, that face there, up there, that looks like mine, it's not mine, it's my sister.
Yes, please.
So I should start, you said? Okay, good night, everyone, and welcome again to an awesome Thursday experience. We are so delighted that you have chosen to take your time to spend with us. If you have been here before, you know that you are prepared for an amazing experience, one where you come to be informed, one where you feel comfortable enough to post your question in the chat, and one where when you leave, you are edified and invigorated to share what you have learned. Tonight, you are looking at a familiar face that normally hosts this program. And yes, this is Dr. Patricia Henry. I am the sister of the Women's Ministries Director of the East Caribbean Conference of Seventh-day Adventists. I am not sure how much of that was heard.
Most of it. You're the sister of Sister White.
Oh, wonderful, good. And so, yes, I am the sister of the younger sister of Sister Hoyt, and I am delighted to share this space as she is held up in other meetings, and as everyone knows, always so involved in God's work. Tonight, we are broaching a topic that is significant to each of us, and it is significant to each of us because we are, most times when we think of breast cancer, we think of women, but I'm sure tonight you'll be amazed to know that breast cancer affects everyone. So if you're here tonight as a woman, it affects you. If you're here as a man, it affects you. It affects our daughters, our sons. And so I pray that you would give our presenter your undivided attention as she shares with her from her wealth of knowledge. And because she has not sat with us before, I am sure many of you are wondering who is the beautiful young lady in the orange top. Well, that young lady happens to be Dr. Marcia Cambridge Maxwell, and she is truly a daughter of the Caribbean, born in Guyana, in South America, and she obtained her Bachelor of Science in Medicine, Bachelor of Medicine degree in surgery from the University of Guyana in 2007. And in December of that same year, she chose to emigrate to Barbados, where she started to work at the Queen Elizabeth Hospital in January of 2008. She obtained a diploma in family medicine from the University of the West Indies, Cave Hill. So she is globe-trotting across the Caribbean, isn't she? Currently, she's a registrar at the Cancer Treatment Department of QEH and plans to specialize in nuclear medicine. She is a member of the Barbados Association of Palliative Care, and she is also the wife of Dr. Luxburg Maxwell and the mother of two beautiful daughters, ages 10 and 4. Currently, she's a member of the Bridgetown Seventh-day Adventist Primary School Board, and she also serves as a health and temperance leader at the Maranatha Seventh-day Adventist Church. She has been in that position for 9 years. Currently, she also serves as the religious liberty leader and master guide director of the same Seventh-day Adventist Church. She says that her personal mission in life is to know Christ and to make him known. So, ladies and gentlemen, you have heard what her foundation is, and so I invite you to listen attentively. And do remember, if you have questions, to pose those questions in the chat, and they would be answered at the end of the presentation. So Dr. Maxwell, the floor, the platform is all yours, and please enlighten us.
Thank you very much, and good evening, everyone. Thank you for the opportunity to present this evening. I know in the East Caribbean Conference and even further field now because of Zoom, we have many resource persons who I would have been odd to sit at their feet this evening. So I am very thankful for Sister Hoyt and the Women's Ministries Department for asking me to share the little I know and have experienced about breast cancer. Thank you also for joining us. I know the options are numerous, and I'm very glad you chose to be here with us, and I pray that you will leave here more blessed and more enlightened than you came. Now we're going to go straight into our presentation, which should not be long. As you heard, you can post questions in the chat, and afterwards we will address them. We're just looking at a brief review of breast cancer. During this presentation, we hope to garner a general overview of breast cancer and cancer in general, also to be aware of the different classifications of breast cancer, the screening that is advised, risk factors, symptoms, and treatments for breast cancer. And interestingly enough, there are many benign conditions which can masquerade as breast cancer. We're going to take a look at some of those. Now, generally speaking, the incidence of breast cancer worldwide is really striking. And for us here in the Caribbean, it is 50 women for every 100,000 throughout the Caribbean has been tested and diagnosed as having breast cancer. And in the US alone, we will see that in general populations, this incidence can vary with race and other demographics. But in the US alone, we see that there's a very high incidence of breast cancer in the Caucasians, in the Blacks, and in East Indian, Asians, and other Pacific Islanders. In Barbados, according to GlobalCon in 2018, in Barbados, breast cancer was the second most common, and of course that is second only to prostate. And in 2018 alone, we had 1,295 cases of cancer, new cases of cancer being diagnosed, and out of those, 164 were breast cancer. And out of the 721 cancer deaths we had in 2018, 94 of those were as a result of complications or advance in breast cancer. Now, I want to say right up front, as our host would have pointed out, breast cancer is not only an issue to concern women. So if you only share this link or this invitation with women, please make sure that men are aware of this presentation as well that is happening. And if you have men at home, please call them around the computer, the TV to get some information about breast cancer. Now, in general, when a cancer develops, there's a loss of the mechanism for cell growth and cell death. Normally, every cell has a lifespan. After a certain period of time, the cell undergoes what we call programmed cell death. Or if the cell is damaged for some reason, it undergoes that programmed cell death and there's no repair. Now, cancer cells do not follow that law. Cancer cells are, first of all, damaged cells, and they continue to multiply and change their format and their structure and their responsive mechanism, and they continue to grow out of control. And that is why it grows into a mass or a lump or a tumor. So cancer cells do not follow this programmed cell death that is supposed to happen in normal physiology. And this is another demonstration of that. The normal cells, when a cancer develops, we see an accumulation of abnormal cells that continue to grow out of control, and then they breach the capsule, the lining, wherever they are found. And then what you're seeing in yellow is a blood supply. They start to grow their own blood supply. And once they've developed a blood supply, they can receive nutrients and continue to grow and grow even further. And they can also spread to other areas. So that's how cancers operate in general. So another way, and I found this very interesting slide that puts it all together quite nicely. Cancer cells are cells that can be said to be behaving badly. And it's an overproduction of cells that turn into lumps, and they can take over. And this is very important because of where they are. The symptoms can vary, but because of the size, they can cause pressure symptoms and press on vital organs, impairing their ability to function and to have certain things that should be flowing through them flow properly. Now, particularly in terms of breast cancer, let's look, for example, at the start at normal breast tissue. And so we could get an understanding of breast cancer. So this is our normal tissue here, and any of the tissue that you're seeing can be affected in a case of breast cancer. This is the front view, and this is our side view. So these are the lobes that continue up lobules that produce milk, and via that milk is taken via the milk duct, these ducts here, to the nipple, and breastfeeding happens through these ducts and these lobules and these lobes. The areola is the dark tissue around the nipple, and below the breast tissue, we have muscles, we have bones. You can see some cross sections of the ribs there, and there's also a lot of fatty tissue surrounding these structures within the breast. As the person ages, the fatty tissue turns into fibrous tissue, and we'll come back to that later on. Also involved in breast cancer and important for us to understand are some structures called lymph nodes, which help to drain secretions, drain fluid, or drain lymph, it is called, from the breast and to surrounding structures. And I'm sure most of us, when you would have had a cold, you might have felt a swelling behind the ear or under the chin or somewhere like that. Those are lymph nodes, and they're responsible for having inflammatory tissue and having an inflammatory reaction when there's an infection on board. So this the lymph nodes play a very important part in a lot that has to do with breast cancer. Now, there are very different types of breast cancer based on the structures within the breast. Remember, we said that there were some ducts that take the milk that is produced in the lobules or the lobes to the nipples. So those ducts you see here in red, those can become cancerous, or the cancer can be found in those structures. The lobes themselves, in this case, we have the lobes and the ducts that are affected. You can also have inflammatory breast cancer where the skin over the breast appears to be inflamed. It can appear as a rash or redness or some form of irritation. And oftentimes it can be misdiagnosed as an infection of the skin over the breast. This is lobular carcinoma, lobular cancer of the breast, when only the lobules or when the cancer starts in the lobules. And there's another type of cancer called mucinous, where the mucin tissue, it's like a gelatinous tissue, is found in the breast. I like this image that I found. We can see one of the ducts here. Remember, we said the milk is produced in the lobes or the lobules, and it's taken via the duct to the nipple. And here we see the cancer in the duct. Here we see the cancer in the lobule. And this is a cross section of the duct, a healthy duct, where we see nice healthy cells surrounding it. And then we start to see cancer cells or abnormal cells starting to build up. In this case, it is not cancer as yet. Over here is where we start to see the cancerous changes inside of this duct that we see lining here. And after a period of time, the cancer can break through the lining of the duct and start to spread via the same lymph nodes that we saw or the bloodstream, and take the cancer cells to other tissues far. Now, this is another classification of breast cancer. And I'm going through the pains to go through the many different classifications of breast cancer, because we need to leave here understanding that if we have 10 persons in this meeting right now with breast cancer, they can have 10 different types of breast cancer, and therefore require 10 different types of treatment to treat those breast cancer. So this is another classification. Again, this is based on the structures that are involved, and this is based on also whether they have started to invade or infiltrate other tissues surrounding them, and in which case we call it ductal because it's in the ducts, but then it's infiltrating somewhere. And it's very important to know this classification, because the cancer can be in the where it has started confined without breaking those lining of that area. For example, in the duct, as we said just now, in which it is called in situ carcinoma. So it is stage 0, stage 1. It's very, very early stage breast cancer, and it has not broken any lining, any barrier to start to go anywhere. However, if it has done that, it is we would call it invasive or infiltrating carcinoma. And based on the structures involved, we can have infiltrating ductal carcinoma, infiltrating lobular carcinoma, and so on and so forth. So the classification is based on several different things. And the classification is important because, as we see, for example, invasive ductal carcinoma is the most common. And this is fortunate because invasive ductal carcinoma is associated with the best prognosis, as is the invasive lobular carcinoma, which is quite rare compared to the ductal. But what you're seeing in yellow, those are associated with a better prognosis. 80 to 90% of patients will be alive after 5 years. We call it overall 5-year survival. When we're speaking about cancer survival, we normally speak in terms of 5-year survival. You see the best outcomes are the ductal carcinoma in situ. This is the one that we said before, that was quite early. It has not broken that lining of the duct to start spreading anywhere else. So these in situ cancers that are quite localized, those have a better prognosis or overall outcome. Now, in addition to understanding which tissues are involved, there's something called staging of cancer. Breast cancer is no different. We have from stage 0 to 4. 0 being a case of quite localized. There's no risk of the cancer spreading or returning, and local treatment is usually adequate. And as we see, 100% survival rate. However, stage 4, where the cancer has spread outside of where it has started, that is associated with only a 16% survival rate, which might look very bad compared to what you're seeing on the screen. But for stage 4 breast cancer, surviving that is really a miracle and an act of God, and 16% is still not bad, and it's testimony to the treatments that the various cancer societies around the world are working on tediously. Of course, we would like to see this 16% much, much higher than that. Now, in terms of the staging of the breast cancer, certain things are considered, such as the size of the mass that is found, if there are lymph nodes involved, and the other structures that might have been involved as well. Remember, we looked at that anatomy early on, and we saw that there were ribs, there were muscles, and different structures in association with the breast tissue. So all of those play a part in the staging of the breast cancer. Let's take, for example, a stage 3C disease. In this case, you can have an invasive tumor, so it's invasive. Regardless of what size it is, lymph nodes are significantly affected. So the surgeons would have taken out the breast and sent it to the lab, and they would have found more than 10 or at least 10 lymph nodes affected. And that is stage 3C disease, regardless of the size of the tumor. However, let's say we didn't have more than 10 lymph nodes involved, but the lymph nodes by the collarbone, those were positive, those were affected with cancer, then it's still stage 3 disease. If the internal mammary lymph nodes, if those were affected at least, even if it's just one, or with at least one of the nodes in the axilla, in the armpit, if those are positive for cancer, then regardless of, even if you have a tiny, tiny lump in the breast, that is still stage 3C disease, which is quite advanced just before stage 4. Now, also with classifying breast cancer, so we looked at which structures are involved. We looked at if lymph nodes and adjacent tissue is affected, so we have staging. But even after we stage the breast cancer, we still need to have further information. Every breast cancer sample should be sent for these cells or this further testing, where you see ER, PR, that is estrogen receptors and progesterone receptors. And here you see HER2. These are some structures or some proteins in some cases, and some hormones receptors on the cancer, which tells the cancer how to behave, whether to spread, whether to grow, if to be slow growing. For example, estrogen positive breast cancers that are HER2 negative tend to be very slow growing. And those are associated with a more favorable outcome, as you see here on the screen. There's what is called triple positive breast cancer, where the cancer is positive. It has these proteins, HER2, that tell them to grow. It has these hormones that are estrogen and progesterone receptors, I should say. And the HER2 proteins, positive breast cancers, those typically like to spread to the brain and tend to be quite aggressive. So too the triple negative breast cancer. So you would have sent the specimen to the lab and it would have come back saying that this cancer does not like estrogen, it doesn't have estrogen receptors, it doesn't have progesterone receptors, neither does it have the HER2 protein. So it is triple negative. So this tells us that this is a fairly aggressive, a very aggressive breast cancer that we're dealing with, and therefore that will guide our management. Another thing that we look at is whether it's well differentiated, moderately differentiated, or poorly differentiated. If you're gonna have a cancer, you wanna have a cancer that is well differentiated. In other words, the cancer has clearly made up its mind what it wants to do, how it wants to behave, what kind of cells it wants to have, as opposed to a cancer that is poorly differentiated, that can do anything. Those are associated with a poor prognosis. So in terms of breast cancer, assuming that you don't have many high risk factors, assuming that you caught it early, and there's a well differentiated estrogen positive, HER2 negative breast cancer, that is from the slide in front of us, that is the better breast cancer to have based on these markers. Of course, there can be other confounding factors that cause, even though that seems to be a very good a good breast cancer associated prognosis, maybe there's some other risk. Maybe it was mucinous, maybe it was in the inflammatory type, or something else that would cause it to behave badly. All right, so this is just one of the classifications, and every breast cancer case has to be classified on all of these headings for us to know which type of cancer we're dealing with, and therefore determine the type of treatment the patient needs to have. So being an early stage is not enough for us to decide what treatments are going to be necessary, and etc. Now here we see the same mechanism I was talking to you about just now in a different perspective. The triple negatives are associated with a worse outcome. They tend to be more aggressive. As we said just now, the ones that are HER2 positive are somewhere in between, but you want to have a breast cancer that is estrogen positive, and that is has implications for treatment as well, because there are many more agents that can be used to treat estrogen positive breast cancer. For example, hormonal treatment, and the patient may avoid having chemotherapy and that sort of thing. When we're dealing with a triple negative breast cancer, the options are quite limited, and we need to not only give chemotherapy, but we need to be very aggressive with the chemotherapy that we give. And in terms of follow-ups and so on, triple negatives can have chemotherapy, have a really good response, and then in a very short time, maybe you do the chemotherapy before surgery, and then they went to have their surgery. By the time they come back to you on the chest wall, they have recurrence already. However, I must say the triple negatives, when they do well over, for example, 2 years, 3 years, they tend to be the good breast cancer survivors. Estrogen positive breast cancers, even though they're slow growing, and there's a lot of ammunition that we have to treat them. After people can be cancer free for 10 years, I've seen a lady only last year who was cancer free for 16 years, and then she came back with full blown stage 4 disease. She had a recurrence, and within a very short space of time, she demised. So there are different things that you must take into consideration when classifying cancers. Now, there's also the BRCA classification, and many of us would have known about Angelina Jolie in 2013. She did the screening test and found that she was positive, BRCA positive, and opted to remove both of her breasts. And many people followed suit in going and getting BRCA screening. But BRCA screening is only recommended in cases of very, very high risk factor. For example, you have many relatives and close relatives with breast cancer, then you want to go and do the BRCA screening. Or in persons who are very young at the time of diagnosis, they should have BRCA screening. But as you can see here, the blue is negative. And in those cases, you see how many, the most of the cases will be BRCA negative. So the screening is not indicated just while like that if you don't have any obvious risk factors like young age. As we can see, the what is in orange, the risk of being BRCA positive was higher with the younger population. So you don't have to go and do BRCA screening if you don't have a very strong family history or you're not very young at the time of diagnosis. One of the reasons for doing the BRCA screening, even after you have been diagnosed, is to assess your risk of having cancer coming back or coming in the next breast. So screening in general. Now, this is definitely not a one size fits all, but this is general, very vague, just scratching the tip of the iceberg for non-scientific minds. Or if I were giving this presentation to medical students, I would be very, very more detailed than this slide for screening, because it varies a lot. But in general, according to the American Cancer Society, women ages 40 to 44 should at least have the discussion with their primary care providers, their GPs, their doctors, about regular annual breast screening, having screening mammograms if they wish to do so. But above 45, then it's absolutely recommended that you get one every year. When you get to 55 or older, you can start doing it 2 years, or if you want to continue every year, you can do so. As I said, if you have risk factors, if persons in your family were diagnosed with breast cancer, then this needs to happen much earlier than 40 years. If you have a high risk factor, let's say you had breast cancer in the previous breast, at 55, you're not going to switch to every other year or anything like that. You're going to continue with your yearly mammograms. And the screening is not only mammograms, but you also should be getting examined by your doctor. And we're going to come to the breast self-examination, but we're going to come to that. Right now, let's look at the risk factors for breast cancer. And this is in no way exhaustive, but we can see we're climbing the slope as we go ahead. So of course, women are more at risk than men, but as we said earlier, men should not feel in any way secure about that. About 1% of all breast cancers are found in men. Having no children also increases your risk, and that is because of a prolonged exposure of the breast to estrogen. You would not have undergone those 9 months of pregnancy and then further months of breastfeeding in which those changes happened in the breast, decreasing your risk factor and sparing you from that estrogen exposure. Incidence, the puberty, and it's very important for us to understand this, because this is a problem that we're having with our young girls right now. Having their period early at an early age, we call it early menarche. And then also persons who go into menopause at a late age. That means you have a prolonged exposure to estrogens. And when I say early puberty or early menarche, I mean before 12. We don't want our young girls starting puberty or starting to have their period before 12. And a lot of the time, the reason that happens is because of childhood obesity and the estrogen-rich foods that our young people are eating causes them to start having their period early, because there is a relationship between body weight and body habitus and the age at which a girl starts having her period. As a person increases with age, they're also at risk of having breast cancer. Cancer in general is supposed to be a chronic disorder, something associated with old age. But when we're seeing it in younger persons, and when that happens, it tends to be more aggressive. Of course, genetic predisposition, meaning having family members who have breast cancer. Getting pregnant for the first time at an older age tends to also increase your risk, and not breastfeeding. So breastfeeding for about 2 years is protective. It does not have to be 2 years straight. That is in an accumulative lifetime. So if you would have had several children, the more children You have, I know somebody's going to ask about that, but the more times you breastfed, the more likely you are to accumulate to 2 years or even older. But breastfeeding seems to have some kind of protection against breast cancer. If you have family history, as I said, late menopause, using hormone replacement therapy. And again, hormone replacement therapy is indicated for several conditions. For example, very bad menopausal symptoms, to regulate your hormonal levels during puberty. Some young ladies have very painful periods and need to have some kind of hormonal treatment. And there are many causes why we might need hormonal treatment, and that does increase your risk of having breast cancer. I must say that the treatments available now, especially for young girls trying to regulate their periods and so on, they're much safer now than they used to be, but there is still some risk. Of course, exposure to radiation in the chest area, maybe to treat another cancer, yes, or maybe because of where you work, you have been exposed to radiation in the area of the breast or any area, increases your risk of cancer to that area. Eating lots of processed foods, as we said, processed foods tend to be rich in estrogen, and this increases your risk. Lack of exercise or obesity, we cannot underscore this enough. Obesity is a risk factor for everything. Obesity is a risk factor for everything. Obesity is a risk factor for every cancer, every chronic disorder, whether we're talking high cholesterol, diabetes, high blood pressure, but particularly this afternoon, we're talking about breast cancer and being obese, being overweight. And I know in the Caribbean, in this part of the world, we associate, being covered with looking good and being productive and prosperous, but it's a very dangerous mindset that we have in this part of the Caribbean. A lot of patients, I talk to them about losing weight, and their first concern is what people are going to say. People are going to say they have AIDS. People are going to say they're getting pulled down. People are going to say they're suffering, and all of these things they tell you, and they're not ashamed to tell you that. In this part of the world, men also like to see women who are more covered, big boned, and we're paying the price for it. So we said obesity is particularly after menopause is associated with a high risk factor for breast cancer. Lack of exercise, I can speak whole night on the lack of exercise and the risk with cancer. But these are the risk factors, and maintaining a healthy weight, no alcohol, and exercising, these we cannot stress these enough. Now I'm going to say this here because this is something that we're seeing as well. Lots of young girls, especially trying to have larger breasts, are overdosing on these foods. And as Seventh-day Adventists, a lot of us, and not only Seventh-day Adventists, but vegetarians, a lot of these foods we use a lot of as well. So we really need to remember that everything in moderation. Too much of anything is good for nothing. So even though a lot of these foods you see here have good benefit, they're rich in estrogen and the phytoestrogens, which predispose to breast cancer. So we really need to make sure that we use even the good things in moderation. Let me just put a plug here for male breast cancer. In terms of the male breast cancer, the main risk factors are elevated estrogen levels, whether they have a hormonal imbalance or whether they've been taking estrogens to treat other conditions. Radiation to the chest wall area, the breast area, and a family history of breast cancer increases their risk of getting breast cancer. Their risk is only 1%. As we said, of all breast cancers will be men, but the risk still exists. And you don't know who's going to be in that 1%. For the time that I've been working, where I've been working 7.5, almost 8 years, I've seen about 6 male breast cancer patients. The most recent one up to a few weeks ago who's about to start treatment recently. So it's something that we really need to take seriously. Now, in terms of the signs and symptoms of breast cancer, these are all signs to take note of. The veins in the breast can become suddenly distended. And the main thing to note in examining and looking at the breast, looking for symptoms, is that usually it happens in one breast. So most of the time, if you find something and you see it exactly the same way in the other breast, then it's likely to be that was normal for your breast. But if it's only on one side, that is a red flag that this something may be wrong here. So you can have the distended veins, the discharge from the nipple, The skin can be tinted or puckered, or destroyed in any way, distorted, inflamed, looking red, looking like a new rash coming out. It can be retracted, pulled back. It can be bunched up. You can just see it thinning so that under that skin in that area seems to be shining, like if something, a light is under it. Change in the size, whether it's getting bigger or fuller than the other breast. Retraction of the nipple in itself, redness, it can be warm, there can be swelling, especially in the case of inflammatory breast cancer and recession, as we said. So breast self-examination is very important, an important part of screening. We looked at the mammogram, we looked at the getting your doctor's to examine you regularly. I know a lot of patients tell me they don't have, they don't have no problems, so they don't go to any doctor. But even if you feel the best you felt in your whole life, you need to go and start having at least yearly 6 monthly checkups with your doctor, checking for pressure, sugar, high blood pressure, high blood sugar, cholesterol. Examine your rectum, getting a rectal exam for different cancers associated with rectal growths and bleeding, vaginal exam, pap smears, prostate checks, and of course your breast checks. So when you look at the breast, you're advised to do so every month, around the same time every month. If you're still having your periods, you should do so either before your period or just after your period, but do it around the same time every month. And these are some of the things you're looking for. If you're a man, you're looking for these things as well. So you want to check in front of the mirror. You stand up, you put your hands on your waist, and you clench and you look at the mirror, and you're looking, you inspect first of all for any differences, any discoloration, whether the nipple is retracted or not, any redness dripping from the nipple. Also, you should squeeze the nipple gently, checking for any bleeding or discharge. It is normal to have sometimes a clear discharge, but it should not be milky and it should not be bloody. You should also try to pull the nipple and feel for any lump. And you do this, you're looking, you're feeling, you feel lying down, you feel sitting up. You do it in the bathroom when your hands are nice and soapy and the skin is slidey, and you can slide your hands over the breast and feel the tissue. And I'm going to share a video at this point. Can somebody unmute your mic and tell me if you're seeing it clearly, please?
Yes.
Yes.
So you see, the idea is to not take your hand off of the breast. You want to slide your breast and touch on every tissue. You don't want to raise your hand off of the surface because you might miss a spot. And whatever technique you use to do, you can go up, down, you can go in a circular motion. The idea is to use that technique every time you examine your breast. So you will get familiar with your breast and pick up the slightest change. And you want to go all in the armpit. You also want to squeeze the nipple gently, checking for any bleeding or discharge. And repeat this motion lying down. You can, you do it in the bathroom. You do it sitting up with your hands on your waist in front of the mirror. And you do it around the same time every month, and get familiar with what is normal for you. So the slightest change you're able to pick up. Now, in the cases of the male breast, the most common symptoms that you would see is a lump. You would see a lump, maybe a nipple discharge, or you would see an area that looks like an infected sore. Also, the lymph nodes get swollen. So when you examine under the armpit, just like the women, you're feeling for any lumps, any swellings by the collarbone, by the neck, anywhere in that area. So men need to be doing their monthly examinations as well. Now, this is just a slide showing a few pictures of male breast cancer so that we can have an appreciation for what I'm talking about. The case here, this is inflammatory breast cancer. So you're just seeing some redness and what looks like just a rash. There's no change in the size of the nipple, the size of the breast, or any discharge or anything like that. In this case, it looks like a sore, an infected sore. Some people might think they have an abscess and they got infected or something like that. And they would have dismissed it when it's breast cancer. All right. Now, in terms of working up, if we start with our examination and you detect a lump, you repeat the self-examination in 1 month. Normally, when it comes to being suspicious for cancer, we normally tell patients to observe a finding for about 1 month. So and no more than that. So if you feel a lump, you feel something that you're not too sure about, you check it again in 1 month and you keep observing it for that month. Also, if you're examining the breast and you don't feel anything, you continue doing your breast self-examinations every single month. Don't get weary of doing your breast examinations. If you feel a lump, then you need to, in some cases, the doctor would send you to get a mammogram or an ultrasound of the breast. If you're below a certain age, it will be an ultrasound because the breast tissue is different and less fatty, and older women will need to have mammogram because the breast tissue is more fibrous. You see the structures better on a mammogram rather than the ultrasound. So based on the age, the doctor might send you for some form of imaging. But once you feel a lump, most likely you're going to go on to have a biopsy, where the doctor takes just a part of the tissue you're feeling and send it to see if it's a cyst, if it's cancer, whatever it is. If there's no suspicious lesion on the imaging, many times you're not sent for any biopsy. The doctor would again monitor it. Needless to say, many times a mammogram can be negative, an ultrasound can be negative, and the person still has a palpable lump and it still turns out to be cancer. So there's no one test. You normally do your self-exam, the doctor's exam, some screening, and biopsy. Now, this is another workup that we go through. You do your screening mammogram. In 90% of the cases, they will be negative, and you just do your regular follow-up. In 10% of the cases, however, you need to have something further. You can go and have an examination or some other kind of evaluation. Even sometimes after mammogram, you still ask for an ultrasound. And 75% of the cases, it will be normal. You go on to have routine follow-up maybe in a year or 6 months. In the case it is not, you then need a biopsy. Again, 80% of biopsies will be non-cancerous. And you just continue getting regular checkups. The doctor may say repeat the biopsy or repeat the mammogram in a space of time, but 20% of breast biopsies turn out to be cancerous. And in 80% of those cases, it is early stage breast cancer. So I just say this to say that breast cancer is not in and of itself a death sentence. Now this takes us to the treatments of breast cancer. And I want to spend some time here and establish that the treatment that is given to a patient with breast cancer can vary from person to person extensively. As we said before, you can have 10 persons in this meeting with breast cancer, and they require 10 totally different treatments. You will not believe the education and miseducation that goes around pertaining to the treatments. Somebody might tell somebody that they have breast cancer, and the person will say, oh, the doctor's going to do the ABCD, they're going to give you ABCD, or whatever the case is, based on what their experience was or based on what they witnessed their relative going through. But that's not necessarily this case. As we said earlier, there are things that we need to take into consideration, and this is very individualized. So the stage of the cancer that the person is presenting with, if it's stage 0 or if it's stage 4. Stage 4 means that it has gone outside of all the breast tissue and the tissues around the breast, and it has started to spread to other non-breast tissues like the lung, the bone, the liver, the brain. Once cancer starts to spread outside of where it has started, it's stage 4. So if you're dealing with stage 4 disease, the treatment that is recommended is going to be way different from if you're dealing with something that is in situ, as we said at the beginning, that is well localized very early. If you're dealing with cancer, and remember we talked about whether it is ductal or lobular, or whether it's inflammatory, and all of these terms we looked at earlier. All of those things help to decide what you will need, what treatment will be indicated. We also spoke about the chemicals, the fuels that tell the cancer how to behave. If we're dealing with the estrogen positive stage 2 breast cancer, the treatment will be different than if we're dealing with estrogen negative stage 2 breast cancer. if it's a hormone positive, if it's a HER2 positive breast cancer. We said HER2 is one of those proteins or the growth factors that go on top of the breast and tell the breast to spread and to behave aggressively and to return even after you would have been treated and seem like you have a cure. The HER2 positive subtype is at a high risk of recurrence. So because of these different things, even though it might have seemed like we caught the cancer early and we're dealing with early stage breast cancer, we are going to be aggressive, and certain treatments are going to be indicated even though it looks like the cancer was early. Also, if it's triple positive for all of those cell types that we looked at, or if it's triple negative where it has a high tendency to behave aggressively. A lot of the times breast cancer that is found in many family members sometimes can be triple negative. Also in the young ladies, the very young patients tend to have the triple negative breast cancer, which is the aggressive type. And that comes to personal. So if we're dealing with a young person with breast cancer, we need to be very aggressive with that person. The treatment is not going to be the same as if we're dealing with an 80-something-year-old person. We're going to be very aggressive. However, saying that, we need to appreciate that the individual might be more inclined to want the breast conservative treatment. So the young lady might be less inclined to want to have the whole breast removed. They might be concerned, and I have several patients who are concerned about their ability to have children or their ability to breastfeed. We had a patient with a very aggressive, a very large tumor, and she insisted on completing her whole pregnancy without having any type of treatment at all, even those that are safe in pregnancy. And then when her pregnancy was finished, she insisted on breastfeeding. And we're begging her to wean him off the breast so we can start your treatment. But patients, when it comes to age, the personal choices vary, and we always have to take the person's choice into consideration. We can't force people to take anything. We can educate them, but at the end of the day, a person's choice is the number one determinant in what treatment they will receive. Also, let's look at their personal health condition. So we might have somebody with a stage 3 breast cancer, triple negative. We want to be very aggressive. We want to give them chemotherapy. We maybe want to do different a whole barrage of treatment through the book of them, but then the person has poorly controlled diabetes with kidney failure and they're on dialysis. Or maybe they have very bad heart disease. Some of the treatment that is indicated for breast cancer, you need to be able to, you need to have a good heart test for us to give it to you. So we always do a heart test first, and if it's not, then we can't give it to you. So despite what the stage and the type of breast cancer might be, and your personal choice, you might want to have everything that we can possibly give you. But because of your personal health, we know that you cannot tolerate certain treatments, and we would end up giving you what we would not necessarily use as first choice. So a person's health has to be taken into consideration. Likewise, we might have, and we do have, many people in their 70s, their 80s, and 90s who are on chemotherapy, who are on hormonal therapy because they are well, they're fit, they're healthy, they're very active. I had a 70-something-year-old lady that tells me she does a 5K every week. And when you look at this woman, she is fit, she is ripped, her muscles are nice and abdomen well toned, and she is up and about, and she is going to be able to tolerate treatment much better than somebody else her own age who has high blood pressure, diabetes, heart disease. They're maybe amputated and in a wheelchair and all of these things. And maybe they don't have the family support and so on to be able to tolerate the treatment that we want to give them. Persons, and this is for chemotherapy or treatment in general, a person, whether or not they're able to stay in hospital for a recommended treatment, or whether they can get time off from work because they might tell you they're in a new job and they don't want to take any time off from work, and they're concerned about that. They're the only provider in their home and so on. So all of these things have to be taken into consideration in determining which treatment is best for the patient, how we go forward. The history, of course, if this is the person's second time with breast cancer, maybe they had cancer of the previous breast, maybe they had cancer in the very same breast and they only did a breast conserving procedure before, and now they're having cancer in the same breast, we might want to advise them to remove the whole breast. Maybe they have a strong family history of breast cancer or other cancers. Maybe they would have had a history of getting certain treatments before. And in terms of chemotherapy and radiation as well, there's X amount of X treatment that you can give a person within their lifetime. So for radiation, you can only give X amount of radiation to one area. So even though radiation might have been indicated because of the stage of the cancer the patient has, the person might have already had radiation in that very treatment field. So we cannot give it to them. So the person's personal history, their family history, their treatment history, all of those things have to be taken into consideration. And I really hope we're understanding that the treatment for cancer is individualized and it's no one size fit all. And the miseducation that happens, I can tell you, in the waiting room of the clinic, it would blow your mind. When you listen to patients talking to other patients and telling them what they should do. And only today, I had a patient come in the room. She was recently diagnosed with cancer, and I had to, this is her second visit. So she was only going to be spoken to about the treatment, what it involves, obtain her consent, tell her when she can start and all of that. But she told me, when she came and I said, how are you? She said, scared. And as I spoke to her, and when I was finished talking to her, she said she don't understand. But the man outside said that when she comes in here, I'm gonna connect a drip to her, and she's gonna get the chemo, and she's gonna feel bad, and all of that. I mean, in the waiting room at the hospital, it's amazing what patients say to other patients, and patients tend to believe them, and they go home and they try different remedies and all of that. But we really need to appreciate that in cancer treatment, there's no one size fit all. There are many types and classifications of cancer. There are hundreds of types of chemotherapy, many different treatments. Sometimes chemotherapy is never indicated or never needed in a particular case. So we need to remember that. In terms of breast cancer, the treatment can be local, meaning we're only treating the specific site of the cancer. That could be by surgery or radiation. Those treatments are only to the cancer site. Systemic treatments, we call it systemic because whether you're taking it in tablet form or drip form or injection form, it goes into your bloodstream and it is circulated throughout the body. And therefore, effects of the treatment, beneficial and side effects, can be felt everywhere. Symptoms like vomiting, nausea, hair falling out, those are systemic effects from treatment that you feel not necessarily in the area where the cancer is, but you can feel it throughout the body. In terms of surgery, the surgery, as we said, it can just be a case of removing the lump. If it is small enough, if it is well localized, if the scans show that it's not extensive, or you can be taking out the entire breast. And the name, whether we do a radical or modified radical and all of that, again, if I were talking to medical students, this slide would be different as well, but it depends on which level of the lymph nodes you're taking out, what surrounding structures, if you're going for the muscle that is on the lining and all of that. It depends on the kind of, the extent of the tumor you're dealing with, as well as the desire of the patient. Whether some patients want to conserve the breast, some patients want it all off, some patients want both off, whatever, all of those things have to be taken into consideration. Radiation, it is again specific to the area of the cancer. You can have external beam radiation, or there's radiation overseas. Some centers can actually plant the radiation pellets on the breast tissue, and they deliver the radiation through those. Or you can have this proton beam, which is a more targeted therapy, but either way, it is specifically in the treatment in the cancer area. So these are local treatments for cancer. Systemic treatments, as we said, they can be hormonal medication. In case of the HER2 positive, it could be anti-HER2 injections, tablet form, chemotherapy, whatever the case is, the treatment is based on, or we use these things to decide what treatments we will give. If we're dealing with early stage breast cancer, in other words, you don't have any evidence of having the disease, maybe you had a lumpectomy or radical surgery as well, and everything was taken out, and there's a low risk of there being any disease still there, but we're still giving you the treatment to reduce the risk. In this case, systemic treatment is given to reduce the risk of the cancer coming back. killing also any microscopic cancer cells as radiation does as well. But in this case, the treatment is not necessarily chemotherapy. It can be hormonal therapy, whether it's anti-estrogen medication, because if somebody has estrogen positive breast cancer, that means it's a cancer where the estrogen tells the cancer to grow and to spread. So we want to give you medication to suppress the estrogen in your body. All of those can be given at early stages as well. In locally advanced disease, so a lot of lymph nodes involved, the skin, the muscles, and so on. But because the cancer is so advanced locally, it is difficult for the surgeons to operate because they will not have enough healthy tissue to close the skin after surgery. When you do surgery for cancer, you want to make sure you get out a good perimeter of healthy tissue around the cancer to convince yourself that you would have gotten out everything. And you want to remove lymph nodes and all of that. But if the breast cancer is so large that it's not likely that the surgeons are going to get closure, then you want to go in and shrink the cancer with some chemotherapy or sometimes hormonal therapy as well to make it more operable. And this too, doing this too, we reduce the risk of the cancer spreading. Even though the person has locally advanced disease, the cancer is not yet in lungs, liver, bone, brain, and those structures, and you want to decrease the risk of that happening. All right. And if in stage 4 cancer, so the cancer is already spread, the reason for doing systemic therapy, hormonal therapy, chemotherapy, treatments like that, is to control the disease, to decrease the rate at which it is spreading, progressing, to improve the person's symptoms. Maybe because of the cancer and the spread, they're having lots of pain, fluid building up in the tummy that has to be drawn off periodically, difficulty breathing, and those symptoms. By doing the chemotherapy, you're able to decrease sometimes the disease burden and therefore improve their quality of life by having less symptoms, and sometimes also to prolong their life. Metastatic disease historically so far does not have, is not curable based on science. However, with chemotherapy, you can try to increase, and other hormonal systemic therapies, you can try to increase the patient's quantity of life and their quality of life as well. So all of these things might be reasons why, even though sometimes you're dealing with a stage 4 cancer or an early cancer, you want to go in with systemic treatment. And it's very important to know this, because patients would ask you, when patients come to us, they would say, but the surgeon told us that they got out everything, so why do I still need chemo? Or why do I still need these estrogen suppressive medication? But there are different reasons why you might still need it. Maybe you have a strong family history. Maybe it was triple positive. Maybe it was triple negative. Maybe it was HER2 positive. And all of these different things we looked at the beginning. So systemic treatment might still be needed, even though we think we're dealing with early cancer. Now, let us look at some other situations where the breast can have a mass, or other conditions of the breast that are not necessarily cancerous. Let us look back at the tissues in the breast. We said we had some ribs under the breast. Sometimes if the person is slim, especially if the breasts are small, you might be able to feel these ribs under the breast tissue, and you should not be alarmed by that. The muscles sometimes, the same way muscles anywhere else get inflamed, the muscles below the breast tissue can get inflamed. They may cause pain. It can be even swollen and irritated. You may be, if it's swollen enough, you may be unable to move, raise your arm, and different things like that. The fatty tissue, when you feel the breast, you can feel fatty tissue, sometimes the mammary glands or the lobules, especially if it's in breastfeeding or pregnancy. But around the same time every month for persons having their period and people who might be going into menopause, they will feel changes happening in their breast, like contracting, like if they're preparing to breastfeed and so on. Those are changes that can happen periodically. That's why the idea is to examine your breast around the same time every month, so you get to know what is normal for you, and that way the slightest change you're able to pick up. Lymph nodes under the armpit, you can have, as we mentioned before, things like an abscess or anything that causes any infection in that area. Any infected nipple or anything would cause the lymph nodes to be inflamed. All of these ligaments and ducts and so on, all of these structures you can be feeling when you examine their breasts, and they can have different conditions associated with them that are not cancer. We said you can have cysts, you can have an abscess, you can have problems with the nipple. You can actually have a tumor, but they can be several different conditions. Now, Let's look at this. Pain, for example, causes of breast pain. Only 2 to 7% of breast pain will turn out to be cancer. All of these other conditions can be causing breast pain, including after surgery. After surgery, the breast and the tissue there, as it starts to heal inside and there's scar tissue forming inside, it can be painful for a long time. Actually feeling a mass, and this is very important to know, only 8% of the times a breast mass will be cancer. All right, there are many other causes for a mass in your breast. A discharge from the nipple, 5 to 21% of the times, this is caused by cancer. There can be many other causes like hypothyroidism, and I mention that one because that is very, very common and it's non-cancerous. Intraductal papilloma is another benign condition. It is associated with a nipple discharge because you have a growth in the milk duct. Remember, we looked at the ducts. So you have a non-cancerous growth there, and it causes the nipple to produce milk. This is not cancer. Fat necrosis. This happens if you had some kind of trauma, some kind of injury to an area in the breast. It has to be severe trauma, of course, and it can look bruised. It can be very painful. You may have nipple retraction. The skin can be changed. Sometimes you can feel a hard lump under the skin as well. Sometimes it can even be painless. But when you touch it, it's tender. All of this is called fat necrosis because you had trauma or injury in some way, maybe a burn even to the breast tissue, and the fat under that tissue has died and broken down, and it's broken down, and you get what is called fat necrosis, death of the fat tissue under there. That is not cancer. And these things are not related to any cancerous transformation in the future. Now, this one is very common, fibrocystic breast disease, and I really want us to appreciate the brown areas on the slide. Those are called cysts. This is fibrocystic breast disease, and you see how many you can see. This usually, it can be just one area, but usually it occurs in multiple areas. And it also tends to occur in both breasts, even though it can occur in one. Now, it's important to understand that even though you have fibrocystic breast disease, you can still have cancer. The two are not related. The two are not one and the same. And science still tells us that there's very little likelihood of any malignant transformation in the future. I have had patients say to me that they were diagnosed with fibrocystic breast disease years ago, and now they have breast cancer, and they believe the diagnosis was missed at the first time. But there's no reason somebody with fibrocystic disease cannot develop breast cancer. It's a totally separate etiology, separate pathogenesis, separate disease altogether. And the risk you have of developing breast cancer with or without fibrocystic disease is the same. So it's very important to realize that. But fibrocystic disease can mimic a lot of the symptoms you get in breast cancer. You can have lumpy breast, some rope-like texture in the breast, swelling, pain, tenderness when you touch, pain in the armpit, and you can even get a greenish dark discoloration as well. As we close, I want to conclude by just discussing some myths and facts about breast cancer. One myth is, as we said earlier, breast cancer being a death sentence. It is not a death sentence. There are many treatments available, and as we see, only 8% of the times the cancer is advanced at time of diagnosis. The important thing is to have regular breast exams, know what is normal for your breast, so that the slightest change you're able to detect, and make sure you're having regular doctor checkups. If you're over the age, make sure you have your mammograms, your screening procedures done. Regardless of your age, if you have risk factors, you still need to, that would tailor your screening procedure. Fact, if detected and treated early enough, the cancer need not result in death. And that's very important to understand. Most of our patients are survivors. We have thousands of people in Barbados with breast cancer, and most of them are going to go on to die from old age or diabetes or high blood pressure, something. Most of the patients are survivors, and we thank God for that. Another myth, if I have bigger breasts, I have higher chance of getting breast cancer. That is not true. It is not related to the size at all. Much research has been done on this, but it's equal risk between women who have large breasts and women who have small breasts in terms of developing cancer. All breast lumps are cancerous. We just saw that this is not true. 9 out of 10 of the breast lumps is not cancer. The important thing, early detection, and it really does save lives. Please start examining your breasts. Please share this information with somebody. Please stop thinking that men are immune to breast cancer and don't need to know these things, don't need to examine the breast, don't need to ask your doctors to examine the breast. That is not true. So I hope this was beneficial to us. And doctor, we can take some questions now, I believe, if you are ready.
Yes, thank you so much, Dr. Cambridge Maxwell. You've given us so much to think about, so much information that one cannot help but have questions to ask. And so I have, collated about 10 questions. And please bear, listening audience, if you hear a question asked that was answered, because some people may have entered the platform after Dr. Cambridge Maxwell would have addressed the specific question. So the first question we have is a discharge from the breast indicative of cancer? I think the answer is no, but you will give us all the answers.
Yes, as we saw on the slide, there is up to a 21% chance that the lesion is cancerous, but not necessarily. That risk factor is as low as we said 8 to 21% of cases will be breast cancer, and that is a low percentage compared to the women who have nipple discharge. So no, it does not mean you have breast cancer, but again, please let a doctor make that diagnosis.
Wonderful. Okay, so I have a couple questions looking at whether or not a mammogram is better than an ultrasound. So could you address that?
For the younger breast, because of the type of tissue in the breast for the younger premenopausal patient, the best, better mode of diagnosis would be the ultrasound, to have ultrasounds of the breast. But as we age, the breast tissue becomes less fatty and more fibrous, and mammograms are better for picking up the larger percentage of the lumps in the breast. We must underscore that you can have a normal mammogram and a normal ultrasound and still have a palpable breast lump. You need, if you're feeling a lump, you need to go on to have a biopsy.
Okay, I was just, as you were answering the question, I thought mammogram sounds like mama, which helps me to remember that older women would do better with mammograms and ultrasounds for younger ones. Okay, our third question is, does breast cancer hurt in the early stages?
The hurting, the pain is not related to the stage. It can hurt, but it can be painless as well. And every breast lesion that hurts is not necessarily cancer.
Okay, all right, that's good to know. And I know you addressed this, but what is the best form of testing for breast cancer?
Okay, so there's no one size fit all again. The best thing is the breast self-examination, the idea of knowing what is normal for your breast so that you will be able to detect the slightest change. So you feel the breast, you examine in different positions around the same time every month. You examine the by the collarbone, squeeze the nipple gently, go into under the armpit, have your self-examination and know what is normal for you. A lot of conditions can cause us to have lumps in the breast that are not cancer. But if you feel a new lump, or maybe one of the lumps you felt before has changed in some way, it has grown, maybe the nipple that the discharge doesn't look the same way it looks every month, because it's normal to have a clear discharge. Maybe the nipple is now become inverted. Maybe you're now seeing a rash, some change in the skin, puckering, or anything like that. It is important to know what is normal for you. So the slightest change you're able to detect. In addition to that, having regular medical examinations by your doctor. Many patients believe because they don't have a diagnosis of any medical condition, they don't need to have a regular doctor. And that is not true. Somebody needs to be checking for things before they cause you to feel sick, before you have symptoms of them. So your examination, the doctor's examination, and based on your age, the ultrasound or the mammogram.
Okay, doctor. So I got a follow-up question. A follow-up.
Felt a biopsy needs to be done.
Okay, sorry for that. A follow-up question to that is, does the frequency of having a mammogram increases one risk of developing breast cancer?
Okay, so a mammogram is radiation. A risk factor for breast cancer is radiation. When we're talking about medicine, it's always risk and benefits. The risk of getting that amount of radiation from a mammogram to cause you to develop breast cancer is outweighed by the risk of you having breast cancer and not detecting it early enough and dying from it. So despite the fact that there is that risk, that it's very small compared to us not checking your breast and not knowing if there's a lump in there. So it's a risk-benefit ratio that we have to look at. There is a risk because it's radiation, but the benefits outweigh the risk.
And that's wonderful to hear, because the person who asked the question indicated that she was told by a doctor that if she had a mammogram for 5 times, consistently, 5 years, in the 6th year, she would develop breast cancer. And this is why, ladies, it's so important to have a second opinion, because as our informed Dr. Cambridge Maxwell just said, it increases it, but it's not a fixed number of times that will result in cancer. Our next question is, are women who do not have any children at a higher risk to get breast cancer? If so, why? I know we addressed it, but some people came in late.
The answer is yes, and because of the prolonged exposure during their lifetime, what happens, the hormonal changes that happens in our bodies every month as we, the whole menstrual cycle, from the time we hit puberty and start having our periods to the time we go into menopause, those are estrogens that our bodies are exposed to, the breast tissue and everything else. We know that breast cancer is a cancer that thrives on estrogen or is driven by estrogen. So when a person is pregnant, that cycle is interrupted for 9 months, and then it is interrupted continuously for during the period for which they breastfeed. So that break from the estrogen excretion and exposure is protective.
Okay, wonderful. Now this question, should someone over 70 have a mammogram?
If there is a clear-cut risk factor, but if you have never had a mammogram before, there are patients that we stop having from having mammograms. When you get to that age, if you don't have a risk factor, you've never had breast cancer in the other breast, as we said on the slide, and those were very general guidelines. After 55, 65, you can actually stop having mammograms. If all of your mammograms before were negative, you don't have any risk factors. Your doctor is fine with you not having a mammogram. That would be very individualized. Every 70-year-old woman is not the same. Some 70-year-old women have a sister, an aunt, a grandmother who had breast cancer. Some of them have had breast cancer in the other breast before, and some of them might have had a hormone replacement treatments. So it varies from person to person.
Okay, I know you addressed the, I think it was cystic fibrosis in the breast, I think you said. So someone is asking, so she said that she has difficulty examining her breast because she has cystic fibrosis, and she was wondering what advice you can give for her with regards to doing any form of self-examination.
Okay, so for fibrocystic breast disease, yes, you can have lumps, ropey consistency, and so on. The idea is to know what is normal for you. Anything outside of the normal is cause for alarm. So you still need to do your breast examinations. It's not like what we call a breast mice that tends to move around the breast. Fibrocystic breast disease, you have a mass masses in fixed areas. You feel your breasts, you know where they are. You know what is normal for you, you know how they feel. Any deviation from that norm is cause for concern. That's why you still need to examine your breasts around the same time every month. So you get to know what is normal for you. Your normal is not your sister's normal, your daughter's normal, your mother's normal. Every woman, no breasts are the same. So every woman, you need to know what your breasts are normally, so you will appreciate any deviation from that norm.
Okay, wonderful. We have a question about lumpy breast. How can I tell if I have lumpy breasts?
By feeling them. If they feel that way, you have your screening investigations, whether it's an ultrasound or a mammogram because of your age. Your doctor examines them, you get a biopsy. You have a biopsy, the tissue comes back saying it's just fatty tissue or cystic disease, then you know, okay, that is your breast consistency. But you still need to continue examining your breast so you would appreciate any deviation from your normal.
Okay. So the next question we have is, if your breast itches, does this indicate cancer?
It can, but not necessarily. As we saw, it could be inflammatory, it could be fibrocystic breast disease, and in a significant percentage of the cases, it will not be, but it can be, especially for men. That is a way that they typically present.
Okay.
So the idea is to get it checked out if it persists, because a lot of times inflammatory breast disease is misdiagnosed as an infected breast, and the patient is treated with antibiotics and all of that. The idea is to monitor any change for a month, and if it resolves, then you're fine. But if it does not, then you need to go on to having a biopsy, skin scrapings, anything like that, to see what is the cause of it.
Okay, final question, at least that I have before me, is coming from YouTube, or is it Facebook? One of the other. And the person is a new mother, and she is asking, what is the probability of getting breast cancer from having a cyst in the breast? This cyst was found just after starting breastfeeding. Should I be worried?
Should get her doctor should definitely know about it, and she can also get a biopsy if it persists. Again, it should be monitored over the period of at least a month to see if there's any change. There can be these changes in the breast during breastfeeding because of the milk production. It can happen during someone's period, and that is why we are advising that you examine the breast around the same time every month. So it's something, if she was diagnosed with it, when she said diagnosed with a cyst, I take it that she's already had the imaging and the doctor would have told her that. I hope also she would have had some kind of tissue diagnosis. But generally speaking, during pregnancy, during breastfeeding, a lot of breast changes can happen. A cyst alone might just be benign.
Okay, wonderful. There's another question coming from YouTube. Verna Nichols asks, can I have a mammogram and an ultrasound on the same day?
Yes, you can have a mammogram and an ultrasound on the same day. A lot of times when the surgeon or the doctor sees you and they examine the breast, they sometimes, based on what the ultrasound shows or based on what the mammogram shows, a lot of time you have the mammogram, and because of the results, the surgeon says, I want an ultrasound. It usually works backwards like that. But there's no danger in having a mammogram and an ultrasound on the same day.
Okay, wonderful.
Especially if the ultrasound is before the mammogram. The women might complain that the mammogram is painful, and after having undergone the mammogram, they may not want to do the ultrasound. And if it's a case where the person has small breasts as well, and the tissues are squeezed together, then you might not want to do the ultrasound on the same day. Your findings might be distorted.
Okay, wonderful. I just wanted to share this with you. Someone said, Kathy Ann Antoine said, Dr. Maxwell, excellent presentation. You are extremely knowledgeable and resourceful. Thank you so much. Just wanted to share that with you. No, I'm scanning through to see if I missed any questions. I'm almost sure I got all of them, but let me just take a quick look. I'm not seeing any. If anyone has a question to ask, this would be your time. I'm sure Dr. Maxwell office hours are very booked. So we are so privileged to have the freedom to engage with her in this space. Okay, there's a question. It says, if one breast suddenly starts to get noticeably larger than the other, can this be an indicator of cancer?
Yes, it can. Yes, it can. That's one of the changes you're looking for.
Okay, and based on what you've said, this person should immediately seek professional help to ascertain whether or not cancer is present and how to move forward with clinical care. Okay.
Correct. Remember we mentioned only 8% of breast lumps are cancerous. So that mass, that swelling can be many other things as well.
Like Dr. Maxwell is trying to make you calm your anxiety if you have it. Because, you know, as she said, only 8%, right, doctor? You said? Wonderful. Next person is asking, if you previously had a benign lump, are you more at risk of developing breast cancer?
No. If the lump was benign, then your risk, for example, like in fibrocystic breast disease or introductor papilloma or the fat necrosis, any of those findings, even the breast mice, they're not associated with any malignant transformation, and your risk of having breast cancer is just the same as anybody else. Also, if you would have been diagnosed with breast cancer in one breast, unless you're BRCA positive or one of triple negative or one of those other bad prognostic, you have one of those bad prognostic indicators, then your risk of having breast cancer in the other breast is just as anybody else who's never had breast cancer.
Okay, that is excellent news for those individuals who may have discovered some lump here or there. I am just browsing again to see if there are any more questions. Let me see. This question, the person is asking, can the stages change?
Yes, they can. Cancer can progress from stage 1, 2, 3, all the way up to 4. In which case the person started out with a localized cancer, and then either because they did not have treatment or the cancer did not respond to the treatment given, the cancer progressed. And it started off with a particular stage and it has moved up all the way to stage 4. Also, in the stages less than stage 4, treatment has been known sometimes to downstage a cancer as well. And the surgeons use that term a lot, because what you want to do when you give chemotherapy, for example, before a surgery, is to downstage a cancer so that the surgeons can operate easier. And a lot of times cancer responds to that. And when the surgeons take out you would have seen that the person had a very good response to the chemotherapy or whatever treatment was given in the first place.
Okay, I have another question here. This lady is asking, I heard that by pressing down on your breast so hard on the mammogram machine, one can increase their risk of cancer. Is this true or false?
No, that is not accurate. The risk, as we said, risk and benefits we talk about in medicine, and the risk of getting cancer from the mammogram is related only to the amount of exposure in terms of the radiation, and that too is negligible compared to the benefits you have from getting the mammogram. But the any discomfort you feel from the mammogram will only be related to things like fat necrosis and those benign conditions.
Okay. Now, if someone has hyperthyroidism, is there a higher risk of developing breast cancer?
No. We see the benign breast changes a lot, for example, in the hypothyroidism, as we said, like the nipple changes, nipple discharges, so on. As we saw on the slide, it was hypothyroidism, not hyper.
Okay.
Changes as well.
Okay. Well, this person is comparing our current COVID state with cancer. She's asking, as with COVID, where you have patients who are asymptomatic, is there a possibility that one can be asymptomatic with cancer and still have the disease?
Correct. So, and that's why we're supposed to be checking, because a lot of times we're not going to pick up a lump in the breast unless it is large enough. But it would have had to start as a small lump. Sometimes, if you don't know the technique for examination, that's why we mention and we stress examine under the armpit, examine the collar by the collarbone for lumps as well. Because if you're not checking, if you don't have to feel any kind of pain in the breast cancer is usually, cancer in general is usually painless unless there's a different type or it's compressing somewhere. So you don't have to feel any symptom of breast cancer at all to have breast cancer. A lot of people, I remember one patient in particular went to a doctor for back pain. And because the doctor was being thorough, he asked her to undress to do a full examination. And he saw the breast by chance. And she just thought it was a little sore she had on the breast and she was dressing it for years. So, I mean, so you have long standing, a lot of times the symptoms from the breast cancer. In that case, she was symptomatic, but just didn't know it. But you can have breast cancer that is asymptomatic and it's growing, it is spreading, and it is causing a lot of damages in your body.
Okay, what about lumps under the armpit? Someone is asking, should I be concerned if I have a lump under my armpit?
Yes, because the lymph nodes from the breast, as we saw in the diagram, they travel all the way under the armpit. That's why part of the breast examination includes examining under the arms. So if you have a lump under the arm, again, as we said, most of the time it will not be cancer, but you need to get it checked.
Okay, I have a question. I remember when I was growing up, I was told that if you got hit or a blow or a lash, you can develop breast cancer. Is that a myth or a fact?
That is a myth. That is the fat necrosis that we were talking about. If the trauma is severe, you can get the tissue, the fat under the tissue where in whichever region can it can die, the tissue, the cells can die, and you can get a lot of pain. As we saw, it can mimic the signs of breast cancer. And it can cause a lump as well, even as those dead tissue, those dead cells form and clump together. You can have a lump and everything. It can be mimic the signs and symptoms of breast cancer, but it's not breast cancer.
Okay, so I have a follow-up question. Remember that young mother who said there was a cyst that developed after starting breastfeeding? She's following up and she's saying, I was not given a tissue diagnosis. Should I ask for one? I have been getting ultrasounds for review. However, no biopsy was done. So should I request one?
Not necessarily. When they do the ultrasound, they have different features that they're looking for. And if it's if it appears non-cancerous, they're not going to ask for biopsy. If it is a classic cystic lesion, she does not require a biopsy. That's why we do the imaging, because the ultrasound is going to tell us exactly the features of it. They will be able to see inside. They will be able to see if there's suggestion of blood flow to the area and all of that. If it's well defined or if it's scattered at the edges, they're going to be looking for several different features that indicate to them whether or not she should go on to have a biopsy or not. If they're comfortable that it's a well-described, well-circumscribed cyst, then she doesn't need to ask for a tissue diagnosis. They're just going to continue to monitor her.
So I have two more questions, actually three, but two of them surround the same idea. So should one use a natural deodorant? I remember always being told that antiperspirants prevent your perspiration from coming out, and that's a natural process, and we should not use antiperspirants. And the question continues, what about the aluminum that may be present in and how can they influence the development of cancer?
Right. So I remember
roll on deodorant.
Right.
With the yes.
Yeah. I remember a few years ago, well, probably like 10 years ago, American Cancer Society would have brought out some literature on deodorants. And there was a long list that even included some brands that you would avoid. But the idea is to read the label carefully and to see what components are in the deodorants, estrogens, whatever it is. You need to read and see, and not just cancer, but people have different allergies and so on. You can have inflammation because of the deodorant as well, not only cancer. But the important thing is to read the labels carefully to see what components they have, and research the individual components if you're not sure. All right, but there has been a risk associated with some roll-ons and breast cancer. There has been a risk.
Okay, so this question, and I'm checking, okay, time. So this person says, my sister was diagnosed in 2005, was treated early and the nipple removed. She was cancer-free for 10 years. It returned in 2015 as fluid in her lungs, which was drained. She received chemo and is doing well after given 3 months to live. Is this common?
Okay, I'm going to answer in parts. If she means if 10 years after being cancer-free, cancer can come back, yes. It depends on the type of cancer, the features of cancer. And as I like to tell people, cancer does not obey the textbook. Cancer does its own thing. So yes, it is common for cancer to come back after any time, at any age, in any way. And the cancer coming back in the lungs means now it is at stage 4. So cancer can come back in the form of a mass, or it can be a lump. A mass or fluid, sorry. So fluid in the lungs means that that's cancer in the lungs. Cancer has spread now to the lungs, and it is stage 4, and that is common. The part about her getting chemotherapy, responding very well and doing well, that is excellent, and I praise God for that. At the Queen Elizabeth Hospital in the cancer treatment department, and personally, I never tell persons that they have 3 months to live, a year to live. I am not God. And I have seen patients who look like, tonight, and I can tell you, when you're on call and you see patients who look like they're not going to make it through the night, and you have your phone, you're on standby, and you're expecting the nurses to call you, and that person pulls through, and sometimes they even leave the hospital and they fight on for months. And then there's some patients who look good. They're talking, they're upbeat, they would have responded good to treatment, and then they demise. Before you know it, you get a call from the police saying this person died at home, or maybe they come into hospital with a clot in the lungs, and in a day they're gone. So cancer does its own thing, and I never tell persons that they have this amount of time or that amount of time to live, because I don't know. And I've learned one thing since I've been working with cancer patients, is that it's not going to happen a second before or after God says. Patients have proven that time and time again.
Okay. So another question on deodorants. So what I think we said, natural deodorants avoid aluminum based on what the cancer folks said.
Deodorants, it is still very sketchy. The research,
okay.
There's nothing that can tell persons not to use this or not to use that. People can say, okay, be careful, reduce this, reduce that, and so on. But with deodorants, the literature is so out, the judges are still out on that. It's very sketchy.
Okay, very sketchy. Take precaution otherwise. So final question, so I think, is can prolonged use of a photocopier, and I suspect they mean the big ones, not the little things. Can prolonged use of a photocopier increase your risk of developing cancer?
Well, it is a form of radiation, and if it's prolonged, as in years and years and years of exposure to any radiation, and the idea is to, when we're using these machines, these equipment, to not stand in front of them. A lot of the times we put things to copy and we're standing in front of it as it's reeling off 100 copies and all of that. That is dangerous for any radiation, even and I don't want to invite a new discussion on microwaves, but any form of radiation, you put something in the microwave, don't stand in front of the microwave while it's on. And we can go on and on about the microwave, but if you're using any form of radiation device, don't stand in front of it. For persons, and the physicists do a risk analysis based on how much radiation and what type of radiation is emitted from different machines and devices. And based on that, workplaces are are mandated to have protective equipment for their staff. So the photocopying machine is not one of those devices where you have to wear lead around your waist or the lead vest or anything like that. Unlike persons working, let's say, in an X-ray department who are doing X-rays all day. So based on the risk of the radiation that's being emitted from the equipment, there is certain protective equipment that we're supposed to use, and the photocopying machine does not have any associated protective equipment that is recommended.
Okay, so, oh my goodness, this thing, it's not stopping. So do cell phone towers pose a risk as well? Some towers are in neighborhoods.
Again, the when companies are opening businesses in areas, one of the things that they do is the environmental safety. They have to establish if this is gonna harm the residents to the area, how far away it needs to be, what degree of radiation is being emitted, and so on. The cell phone towers, and I can say it is not known or published. If it is known by some persons out there, it is not published that you need to be away from it, or it cannot be in the neighborhood, at least where it is placed, because they would normally have different things around it to keep persons a certain distance off. And that distance is supposed to be safe.
Okay, oh dear. So question, if someone does not like to be touched, I guess this is a kind of rhetorical question. Are they going to a breast examine? I guess the person is asking, if someone does not like to be touched, would they even go to be examined? And I think I can safely say that health comes first, not so, doctor?
It is true. And every day you interact with persons who are, very covert, if I can say that. They try to, you have to really coax them into raising their hands so you can get access to the area. I mean, if men can do digital rectal examinations, a lot of times you see them, they don't want to pull down the pants. You say, okay, please expose up to this area, and you go out the curtain and you come back and it's still covered up. And so, and if you can eventually get them to lighten up to allow you to do the examination properly, I believe women or anybody who needs a breast exam can eventually be made to feel comfortable enough with the doctor, the nurse, or the person doing the exam, if the person is trained and qualified and patient enough. But the fact that you're scared of being touched, I see patients like that all the time, and they eventually let you examine them adequately. You just have to ask permission and speak properly.
So I'm so excited about all the questions, but we do have constraints of time. And so I'm just going to look at the last two questions that are here, and then we can move forward with our closing activities. So someone is asking, is a person putting their cell phone in their bosom more likely to develop breast cancer? Is this safe?
Okay, so again, this is not something that has been published, but Marcia personally feels it is not safe. Anything that has radiation, anything that's going to vibrate, any battery operated, anything at all, I will not advise anybody to put it on their person, not only by their breast, but by their groin, by anywhere. I don't think it's wise to do so. And I mean, you can even be on a phone call for too long, and the heat that is generated there. I personally don't feel that is safe, but there's no published literature saying that that is a cause for cancer.
Okay, so final question is medication that is given for cancer, to free us from cancer, has many side effects. I'm trying to translate. One effect is on the bones. Are there any other medications that can be substituted?
Okay, so the chemotherapy, the risk of the chemotherapy is based on the way the chemotherapy works. You have hundreds of different chemotherapy, and they are associated with different risks. But generally speaking, chemotherapy is trying to kill cancer cells. Cancer cells are rapidly dividing cells. So those would be cells that are, for example, in the nails, in the hair, that line the stomach and the intestines. That's why you can lose the hair, the nails can be dark, you can get vomiting, diarrhea, and those symptoms based on where the chemotherapy trying to work. You can also get problems in the bone marrow. because the cancer cells can affect the bone marrow, and bone marrow cells are rapidly dividing cells, and they need to be. So chemotherapy has a side effect of decreasing the blood counts, and that's why sometimes we need to give persons medication to bring those up. But generally speaking, someone who is well nourished and healthy otherwise can tolerate the effects of the chemotherapy. And when the treatment is finished, the cancer cells are dead, but the other cells regrow, they rejuvenate, and the person is able to recover from the chemotherapy. There is no substitute per se for the chemotherapy in the way that it acts, but based on the type of cancer person has, the person, if they may not be a candidate for chemotherapy because of some other condition they have, but they may benefit from hormonal therapy, for example, the medications to suppress the estrogen, to suppress the HER2 protein, and those medications also save their lives. It also decrease the burden of the cancer and cause them to have a better quality of life as well. But it should not be seen as a substitute for the chemotherapy. They work in different ways. Many cancers will require chemotherapy plus hormonal plus radiation plus surgery.
Okay, so the only reason I'm going to ask this question because I think I cannot leave this question out because people need to know about their health. So the question is, can someone have medication instead of chemotherapy?
Chemotherapy is medication. So you mean hormonals or other forms of medication besides chemotherapy? Yes, they can. A patient might be a candidate, let's say they're triple negative breast cancer, a young lady, and we want to give her chemotherapy or be aggressive with her, but she doesn't want the chemotherapy, or maybe she has another condition like poorly controlled lupus, poorly controlled type 1 diabetes, has to be on dialysis or anything like that, and is a poor candidate for chemotherapy. Maybe the chemotherapy we want to give her is bad for her because she has very bad heart disease. In that case, we have to use something else. So hormonal tablets or hormonal injections, anything like that. Also, we have chemotherapy in the tablet form as well.
Okay, true or false? Does having a mammogram and not wearing the protection around you next to your throat can cause cancer?
Yes.
Next give throat cancer. Okay. Yeah.
The machine, the mammogram machine they're using and all of that, they will normally give you.
Can you get throat cancer?
Yes, they normally give you the protective guards to put around the throat, depending on the machine they're using and so on.
Okay, and finally, does having a hysterectomy increase one's risk of developing breast cancer?
Increase?
Yes.
No.
If someone had a hysterectomy, what are the chances of breast cancer?
Well, remember, all breast cancer is not driven by estrogen, so they still have a risk of breast cancer. So they could have an estrogen negative breast cancer, but they still have the same risk of breast cancer like the general population. They can't get cervical cancer or endometrial cancer or ovarian, but they once those have been removed, but they can still get breast cancer.
Okay, so I think that was our last question for the evening.
Okay, good night, everybody. I can see that we really had a wonderful evening. It was very informative. Thank you so much, Dr. Cambridge Maxwell. I realize that persons are now warming up to asking questions. I'm really sorry about that. And so we will have to discuss as to whether or not we will do a part 2 of or a similar program of this nature again. Yes, but we'll encourage you to have your questions in early so that we can focus on answering those questions more. Right now, we're going to invite Pastor Miguel Denny. He is our youth director for the East Caribbean Conference. We're going to invite him to pray for all those. I'm sorry, we are having a bit of water problems at the moment. So, and the water truck has just come, and so we're all excited about getting water. So I'm sorry about that just now. Right. So we're going to invite Pastor Denny to come on and to pray for us. We don't know what is going to come, but there are persons who are hurting and concerned and worried, and we are going to ask him to pray that God will be with us to allay our fears, to give us peace if there is something that we're concerned about, and also to pray for this person who is asking for prayer to be done, a 30-year-old who is receiving chemotherapy. And so we understand that at these times where we don't know how to manage at times, and sometimes not everyone has support systems in place to that they can rely on. And so at this time we are going to point them towards relying on God if there is no other support system, and to reach out to those who are willing to be that person there for them to lean on, to talk to just sit with them at this time. So we're going to ask Pastor Denny to pray for us at this time.
Let's bow our heads for a word of prayer. Father, we thank you for your many blessings towards us. We're happy to know, especially after a session like this, even though treatment for diseases like cancer, especially breast cancer, can be varied among so many individuals. We know that you're a God who can answer every prayer, all sorts of prayers, no matter what the issue. We present to you at this time every woman on this session, every woman we're familiar with, our mothers or siblings, or sisters, or wives, our daughters, that they would be protected and kept safe from this disease, and as well they'll be in the best of health. We also remember those who are suffering from this and any other kind of ailment. We ask that you would be the great physician once more to them and to meet them in their time. Especially lift up this individual, this 30-year-old, who is undergoing radiation treatment. You know the details, you know the ins and outs. And we're thankful that you're able to hear, answer all prayers on their behalf. I pray you bring comfort and hope to this person as well, that they will trust you to look after them and to supply their very need, not only physical, but spiritual. I ask that you would continue to bless our presenter tonight, as she did an excellent job in educating us about breast cancer and what we can do to fight and avoid. I pray you continue to bless her, her family, and her ministry. Thank you for the Women's Ministries Department of our conference for hosting this program, and I thank you for all who would have tuned in tonight to listen, to learn, and to benefit, and even to share with others. As we depart from this prayer, may we never depart from your presence. We all strive to live healthy lives, not only for this life, but ultimately to see you face to face when there will be no more sin, no more suffering, no more death, and no more cancer. Until that, they keep us faithful to you, I ask. In Jesus' name.
Amen. Amen. Thank you so much, Pastor. We want to wish all of you a good night, and we look forward to seeing you next time we have a program. Thank you so much for coming, and please be careful with your health. Don't take anything for granted, and above all, make sure that you take the advice of the doctor and not just anybody who offers it on the side. Dr. Cambridge Maxwell, thank you so much for being here, for sharing with us. You've given us so much to think about. At one point, I was saying, oh my goodness, how am I going to remember all of this? But I know that should we need some more information, that you'd be willing to make yourself available to us.
Yes.
Thank you so much once again. And Dr. Patricia, thank you for being our host tonight. We really appreciated your help. So everyone, it's time to go.